the agenda for today. We've had some wonderful volunteers, and I know I'm biased, but I think it's probably one of our best PA boards that we've had to date. So thank you everybody who has served this year. I also want to extend a huge thank you to Amber Lavender, Jennifer Katzenstein, and the entire nominating committee for their hard work. They worked hard to ensure that we had the best candidates this year. And so with that, the new slate for this year for treasurer is Ashley McHugh. The Huff coordinator is Michelle Campbell. Knowlton coordinator is Leanne Hoonstra. And the other Knowlton coordinator would be Ian Levengood. So I am going to go ahead and ask for a motion to approve the slate of the new board officers.
A motion to approve.
Can I have a second?
Second.
All those in favor? Anyone opposed? Okay, the motion is moved. So thank you guys, and we're excited for the new board to be welcome in starting in the new school year. Next on the agenda, we would like to ask Matt Hall to please come up with us. I also want to ask a couple people who helped out significantly with the gala this year to come please come up for the check presentation. Ashley McHugh was in charge of all of our gala parties this year. She also helped with the finances of closing out the gala. Kate Evanoff was our lead on our sponsors this year. Michelle Mellis was in charge of all of our social media, coordinating all of the class baskets. And then Jennifer Katzenstein, she was the head of procurement. So it takes a village to make something like the gala come together. We had amazing leads this year, and it truly could not have been done without any of them. Of course, Gina Stevens was wonderful leading the way. And so Matt, we would like to present you with a check for $245,000, $429.11. The operating proceeds. So out of that, the operating proceeds actually was $175,000. And we had about 59,000 for the power call. 69,000.
So,
69 for the power.
Yeah,
for the power call.
I want to thank you, the committee, and everyone for a wonderful gala. It was amazing. It was not only was very successful, but it also got us back together as a community, which we needed, and it was a lot of fun. So I want to thank everyone for your hard work, and also for the PA all year. I appreciate everything you guys have done. It's been a wonderful year. Thank you.
Thank you, and thank you to our sponsors.
Oh, you want this?
Ashley, take my place.
Thank you, guys.
Okay, next up, many of you may know Jennifer Katzenstein as the parent of Teddy and PK4, the vice president of the PA board, the lead of procurement for our gala, and amongst many other things. But what many of you may or may not know is that Dr. Jennifer Katzenstein is also the director of psychology, neuropsychology, and social work, and co-director of the Center for Behavioral Health at Johns Hopkins All Children's Hospital. She is an associate professor of clinical psychiatry and behavioral sciences at Johns Hopkins University School of Medicine and a dual board-certified pediatric neuropsychologist. We are so grateful for you to be here today, and we look forward to your speaking.
Thanks, everyone. This microphone isn't great. Can you hear me, like, up here? Is that fine? Okay. It's not my favorite thing to do to, like, stand behind a podium anyway, because this really needs to be more interactive, because we have been through so much in the past 2 years, both at the hospital, of course, in terms of COVID and the impact of mental health on our kids, but also, as Mac noted, as a community as a whole. And so when we think about, and for me personally, when I think about what our children have been through and what we've seen happen, wait, do you want me in the camera?
I'm just thinking maybe.
There we go. Perfect. I really wanted it in the camera. Okay. And I'm gonna look around too. So I do this talk pretty frequently and internationally, interestingly. And so I tried to trim it down for here, but normally I have like an hour. but we only have 30 minutes. So I took out some of the things that aren't typically the significant level of mental health concerns and severe mental illness that we see, but if you do have questions about that, we will touch on suicidality as well, because we've seen those numbers increase. So interestingly, in Florida, over the course of the pandemic, we've had a 31% increase in non-fatal drug overdoses. We've seen at the hospital about double the number of kids coming in with suicidal ideation and attempts. At the beginning of the pandemic, it was interestingly over-the-counter drugs mixed with other over-the-counter drugs, because kids couldn't get the illicit drugs that they were used to getting, like at school. So they had less access to the street drugs. As things have evolved and we've been back in person, we definitely see more combination of over-the-counter and street drugs. 43% of teens in Florida are experiencing depressive symptoms. Pinellas County actually has one of the higher rates of suicidal ideation in teens, and they report right now 1 in 12 to 1 in 13 high schoolers in the county has regular thoughts of suicide. Really interesting, for us it happens far more often than you think. So if you even think about our kids that we contact daily as a whole, more significant symptoms of depression and anxiety. And then 37% with anxiety symptoms, about 1 in 3. And then as I said, at the hospital, over the course of the past 2 years, we've seen a doubling of our number of suicide attempts, suicide completions, as well as increases in abuse and neglect. So the important part to keep in mind for mental health is that mental health concerns are actually a diagnosis of childhood. So we can really diagnose mental health concerns in 75% of kids and young adults prior to age 24, but about half of those kids will wait 8 to 10 years for appropriate diagnosis and treatment. Some of that is Florida. We don't exactly have a state that spends a lot of money on mental health. On average, Florida spends $28 per capita on mental health. When you look at someplace like New York or Maine, we're looking at $800 to $900 per person. So not having a state income tax can really impact us in that way too. Pre-pandemic, I have a whole pre-pandemic talk that we still give, that kids, 1 in 5 kids were going to experience some type of mental health concern. The newer data coming out post-pandemic or endemic, we're looking at 1 in 3 to 1 in 4. So chances are it could be one of our own kids, it could be a kid that we know in the community. There's significant mental health concerns and they continue to be on the rise. So what's most important for me as a member of this community at Canterbury and also as a mom and as a provider is that when you all start to notice concerns in your kids, what are you looking for? And when you go to seek treatment, who should you be seeking treatment from? And what words should they be using? Because a lot of times it is just, I don't know, I went to this provider, it seemed okay, we had a good connection, but are they doing treatment? It's a lot easier with things like diabetes, right? Like, you're supposed to get insulin, right? Like, we all kind of know that. But when it comes to anxiety and depression, you think medications, therapy, but what types of therapy should they be using? What should that look like? So I wanted to go through today, we'll go through anxiety, depression, PTSD, OCD, and ADHD. We'll do it kind of quickly because I want to make sure that we have plenty of time for questions and also plenty of time to discuss, you know, if there's a specific area of concern you want to talk about, or specific things that you're seeing in your kids. So in terms of anxiety, you see the list here. I don't necessarily need to read it to you, but it is beyond what you typically think about in terms of anxiety. So of course, when you talk about anxiety disorders, you're thinking nervousness, anxiety, worry, separation, not wanting to go out. We had a lot of social anxiety for our kids with social anxiety during the pandemic. Isolation and quarantine was super reinforcing. They didn't want to be around other kids, and the pandemic was like, this is amazing. I don't have to leave the house, I actually can't leave the house. And so as restrictions eased, we saw a lot of difficulties with those kids getting back into the classroom, getting back into their normal activities. But things we also don't think about so much are the physical symptoms. Headaches, stomach aches without an underlying medical reason, difficulties with sleep, changes in appetite, pain. A lot of times exacerbations of chronic pain can be secondary to anxiety and stress. So those are the things that I want you thinking about. The other piece of that too, you'll see here, is irritability. And irritability is actually the #1 sign of anxiety and depression in teenagers. Really frustrating because teenagers in general are also just irritable. So it's hard to know what's typical irritability versus what's more significant anxiety and depression But when the irritability gets to a point where you're walking on eggshells at home, any little thing sets them off, it's explosive, that's often an underlying sign of depression, which is actually commonly misdiagnosed as a conduct disorder or behavior problem. So important things I kind of want in the back of your mind. In terms of anxiety disorders, we have a whole list, and honestly our diagnostic manual for psychology and psychiatry changes. It's a proprietary manual, so the company who makes it also makes money every time they change it. And they just changed it like 3 weeks ago. So you see a long list of anxiety disorders here, but if you are seeking treatment for anxiety, in order number 1, to have coverage from your insurance, but also number 2, to have appropriate understanding of what's actually happening, your provider should be talking to you about one of the things you see here. Generalized anxiety disorder, looking at anxiety across all areas of your life, separation anxiety, having significant difficulty separating from you, separating from another caregiver, panic disorder, what we used to call panic attacks. So having those pretty extreme reactions, sometimes with depersonalization, where you feel like you're outside of your body in that moment. Selective mutism, I've seen quite a bit of this during the pandemic, interestingly, again, because our kids haven't had as much opportunity to socially engage. So completely going mute in situations that they're not accustomed to being in or not talking to other people, and then only talking at home and having totally appropriate language skills at home, and then going into a situation and just mute in that moment. Specific phobias, you could go on and on about those. The social anxiety disorder, like I mentioned, so it's significant difficulty going out in public, feeling very anxious, very nervous about any social engagement. Agoraphobia, fear of big groups, going out. I mean, I think at the beginning of the pandemic and as things started to ease, I'm still kind of I think we're all kind of in that like middle ground. You go into a big concert, we go into these conferences now, and everyone's acting like everything's back to normal, and masks off, and it's like, oh, I don't know, like, there's just, still so much more that we're thinking about, and we're used to having that extra mask. For me, the extra layer of you not seeing my face if I made a face at you during a meeting, right? So I'm a little bit more nervous now about just controlling my face. Anxiety disorder secondary to a medical condition. So as you can imagine, something we see at the hospital pretty frequently, fear surrounding needles, having a port accessed regularly, chemotherapy, surgeries, any type of doctor appointment. And then they allow us in the diagnostic manual these two kind of like catch-alls. So if you don't fit nicely into these categories, sometimes you might end up with an other specified or unspecified diagnosis. So sometimes if you don't fit quite right, but there's anxiety there, and the key is it's impacting you in your daily life, then you want to be able to seek treatment. Again, the best way to do that if you want to use insurance is going to be that you have to have a diagnosis. This is what I want to see. In terms of depression, again, you think about depression as persistently sad, anxious, or an empty mood. The thing that really distinguishes depression from anxiety, though, is that hopelessness. Not feeling like there's a future for you, not feeling like anything positive is happening, some pessimism there. Again, you see the irritability. I cannot stress enough that extreme irritability is the #1 sign of depression and anxiety in kids and adolescents. Feelings of guilt, worthlessness, helplessness, and then major changes. If you see changes in activities of daily living, showering, taking care of themselves, hanging out with people they used to enjoy hanging out with, doing things they used to enjoy doing, and all of that goes away, that's a pretty good sign too that more is going on and we might be heading into a depression realm. Again, really challenging during the pandemic because our kids love their devices and they also love not being around us as parents as they get older, it seems. So they're in the room, lights off on a device. And so is that depression? Maybe. Depends on if you can get them out and get them going again. But if you're having a lot of resistance transitioning away from some of those pandemic behaviors, it's something that we want to be watching. Decreased energy, increased fatigue, and then some of those physical symptoms that we've talked about too. So moving more slowly, talking more slowly, changes in sleep, changes in appetite, difficulty concentrating, and then headaches, stomach aches, pain, exacerbations. Of course, thoughts of suicide comes in. So thoughts of death. Again, like we mentioned, in Pinellas County specifically, we have one of the higher rates of suicidality. 1 in 12 to 1 in 13 kids are going to have thoughts of suicide in the high school setting right now. Those numbers are on the rise. So right now, suicide is actually the 2nd cause of death for youth in the United States. So what is hard for me as a provider at the hospital is every single medical condition you think about that we treat, heart disease, cancers, genetic disorders, seizure disorders, strokes, brain tumors, the death rates for all of those combined still don't reach the rates of suicidality in kids, and it's preventable. So early identification, seeking out services is key. In terms of depressive disorders, some typical depressive disorders here. Major depressive disorders, what you typically think about, what you see on TV, sometimes if you see a pharmaceutical commercial advertising medication for depression. Persistent depressive disorder is a lower level of that. We used to call it dysthymia. So a generally depressed mood that's over time. Depressive secondary to a medical condition. Again, if there's another medical condition in our older adults, there's depression secondary to different types of dementias. So something that you would see there. And then again, like I said, you have the other specified and unspecified, because like they catch-all if the diagnosis doesn't fit quite right. In terms of disruptive mood dysregulation disorder, this is a new diagnosis. I don't know, when I first moved here, so 7 years ago, this diagnosis came out. What it's meant to be is a way for kids who are younger, so under the age of 12, to be classified who have disruptive behavior and depressive disorders. This can also be a precursor to like a bipolar disorder. So if you're seeing a kid have lots of ups and downs, some really significant disruptive behaviors, tantrums that last hours on end, that fits into the depressive disorder category, but it really is moving towards a bipolar disorder. And we use bipolar disorder all the time, right? Like it's become kind of our lexicon. People say we're bipolar, or I'm so OCD, we'll talk about that because I did this, this, and this. But in reality, bipolar is really characterized by that depressive state, potentially major depression where our mood is really low, and then manic behaviors. And what I mean by manic behaviors are incredibly grandiose. Our kids will say, I can jump off the roof, I can fly, I am able to do this in the future, I can do X, Y, and Z, and I can have billions and billions of dollars. Excessive spending, staying up all night, and then also hypersexualized behaviors. So if we see a lot of masturbation, a lot of significant sexual interest in engaging with others in a sexual way, those can be signs of a manic episode. Bipolar 1 and bipolar 2 really differ by the times. So it's less important for me to have you really retain all of that information, but to know that there's two levels, that bipolar 1 is going to be characterized by the high highs and the low lows, and the bipolar 2 is going to be high and low, but it's not going to be as dramatic as the high and low. You can also have cyclothymic disorder, where you have hypomanic symptoms over a longer period of time, so not quite the grandiosity, not trying to jump off the roof because they think they can fly, not staying up all night, but some ups, but then still having the lows. And then, of course, we have the other specified and other unspecified. Obsessive compulsive disorder is one of my favorites because I think we use it so much when we're talking about ourselves as kind of like perfectionistic. But in reality, it's comprised of obsessions and compulsions. So obsessions are those repeated thoughts, urges, mental images that cause anxiety. So fears of germs, as you can imagine, the pandemic, for someone who already had OCD related to germs, just shot that anxiety through the roof. And contamination, being around people unmasked, hand washing, the unwanted or forbidden taboo thoughts surrounding sex, religion, or harm, aggressive thoughts, or really any negative thoughts that cause anxiety. Compulsions are the behaviors that you have to do as a result of that thought. So that's where the hand washing comes in, excessive use of an antibacterial or antimicrobial soap. You have to do this urge in order to stop the obsessive thought. Otherwise, the outcome could be harm. So when I think about this, beyond excessive checking, right, checking the doorknob a certain number of times, counting in different ways. I was actually in line at the grocery store a couple months ago, and the woman ahead of me, so clearly her compulsive behavior was double checking that her credit card was in her wallet. So she was standing there minutes after she had already paid, and she put her wallet in her bag, she pulled it back out, she flipped it open, she pulled her card out, put it back in, flipped it down, put it back in her bag, brought it back out, double checked it, and this went on probably for 10 minutes. And I was just so sad. The cashier was like, I'm so sorry. And I'm like, this poor woman physically can't get out of here. Like, don't be mad at her, don't bring the manager over to get her away. Like, her brain cannot shift away from this compulsion to double check that her credit card is there. And it was so, I mean, it was heartbreaking because, again, probably could have been diagnosed in childhood. If we had the resources available, if we had enough workforce, she could be living a life and not spend the next 25 minutes just physically trying to get out of the grocery store. So in those moments, you know, like really, I mean, I guess I just ask everyone for a lot of grace, right? It's really challenging and really difficult, especially when the behaviors reach that level. We do have some nice OCD treatment centers in the Tampa Bay area. Unfortunately, one in particular that's really the best in the state only takes a few private insurances. And that, as we kind of move into therapy and themes, is the biggest challenge. Because Florida is so limited, number one, in workforce, and number two, in well-trained workforce, if you're well-trained, you can be in private practice in the community and only be self-pay and make twice as much money as someone who's working in a facility, because there's so few providers. We actually have one provider in Pinellas County for every 500 kids in need. So it's a challenge because that access piece is what presents concerns. And then beyond that, the well-trained access piece is another piece. So if you ever are needing and you want to talk about finding a provider, please reach out to me, because it's hard to know as a parent, like, what's a good place to train and what should I be looking for. But at the very least, I can provide you names of different evidence-based approaches that I would want someone talking to you about if you're having the conversation surrounding anxiety, depression, OCD, or bipolar. So cognitive behavioral therapy is going to be the number one. There's lots of different types of cognitive behavioral therapies. And the idea is that we're working on cognitions to change behaviors and to change emotions. Now, also your kid can go to therapy for 45 minutes to an hour each week and have an awesome hour, but then literally the rest of the week, they're with you or they're at school. So you can have a great hour, but if your therapist isn't giving you techniques and helping you understand what happened in that session, like, that's a drop in the bucket of the amount of time. So you have to be practicing those skills. Exposure and prevention response, great for anxiety and depression. This is when we're building a fear hierarchy, especially surrounding a specific anxiety. So one in particular I had recently, fear of automatic toilets flushing. So wouldn't even go to the bathroom in public, to the point that this kid was getting frequent urinary tract infections, not going to the bathroom at school. So what do? We start at the base of that triangle. We are just purely showing her pictures of an automatic toilet. Not even flushing, not in real life, like Google images, and linking that to a reward. Then the next step is YouTube videos of the automatic toilet flushing. Then the third step is being in the same hallway as an automatic bathroom. And then at the top of that pyramid, after 5 or 6 more steps, it's physically being in the bathroom when the toilet flushes. And we're providing coping skills along the way. So as you can see, like, that's a therapy that's incredibly structured, goal-oriented, and has different pieces along the way of skills that parents are working on at home. It might not always be that clear-cut. So behavior activation is one of our effective treatments for depression. What you're doing there is, it just purely says getting out and doing something leads to getting out and doing more other things, and that leads to doing more other things and increases and improves your mood. Cbt Manuals, Coping Cat is one, for example, that you can get on Amazon. There's a therapist manual on Amazon and the kid manual, and you don't have to go to grad school to be able to do that. So a great opportunity too to provide a skill set at home, especially if you're reluctant to work with a provider, which I'm totally okay with, or the time and the money just don't make it as possible. There is another whole set of workbooks online that I love, what to do when when you grumble too much, when you worry too much, when you can't shift your mind, when your temper flares up. There's like 7 of them. Those are great home workbooks that you can be working on anytime too. Acceptance and Commitment Therapy ACT is meant for adolescents. So this is something that's a little bit more emotion focused in terms of accepting our emotions and understanding that big emotions pass and that you need to work through them, but not let those emotions control you and control your behaviors. So that one is really nice. And then I didn't put it up here, but interpersonal IPT. Interpersonal therapy adolescent, IPTA, is another great adolescent intervention that kind of has the same piece but has coping skills built into. And then finally, dialectical behavior therapy is one of our primary interventions for bipolar disorder. We want them, like I said, to be family focused. We want them to have strong psychoeducation. So that means support for parents, information being provided to you. Deep brain stimulation, DBS, was recently approved for OCD. That's when we're putting electrodes on and stimulating the brain. Actually incredibly effective. You think about what you see in the movies when we put and like do electric shock therapy, which is actually quite effective for major depressive disorder, but has some pretty significant like muting effects as well for personality and things. So typically not a first, second, or third line of defense. But DBS is improving in terms of not having that muting effect and being better for kind of our moderate depressive disorders and OCD. Supportive therapy, what you think about when you just go in and lay on the couch and talk, sometimes feels amazing, right? But it shouldn't be the only thing that you're doing in therapy. Supportive therapy alone with no other interventions or actual skill building isn't effective. And so if you want to do it and you want your kid to just have a place to vent about whatever they want that is safe and you can just kind of know that they have someone to go to and that communication's happening, awesome. But if you are spending thousands and thousands of dollars on that and you're expecting to see more improvement in symptoms, it's probably not going to happen. So I always just want to be mindful of, making sure you know that you're spending your money on the evidence-based practices. And then finally, medication management. I have a PhD, not an MD. So currently, right now, I cannot prescribe in the state of Florida. Legislatively, there are a couple bills that will go to next legislative session that would make it possible for me to prescribe. However, as a psychologist, that's not my first line of defense, right? I didn't go to medical school for a reason. It was actually because I didn't take inorganic chemistry in college. But if I did, then I'd be a dermatologist and we'd be talking about Botox instead right now, which I also love. So medication management won't ever be my personal first line of defense unless we think that it's actually what you really need or the symptoms are so severe that we're talking about more significant suicidality. I like to give you a little skill because automatic thoughts are something that we all experience all the time. They're an initial brief thought that pops into your mind when something happens around you that you may or may not have a context for, but we all kind of provide our own narrative to every situation. And it's useful to stop and address our own narrative and address our own automatic thoughts to say, okay, so was that really happening or did I manifest that myself, right? So they're distorted thoughts, they're dysfunctional, that we accept to be true. And part of cognitive behavioral therapy